what I'm going to ask folks to do is hold your questions till you get a mic. I was asked to please ensure you have a mic when you ask a question. And hopefully that sparked some thinking. So I'm just going to, I'm going to ask if folks have questions, and if they don't, I'll start asking them. But does anybody have any questions they want to start with? There's one right there. So give us your name and where you're from, and I'll repeat your question because I guess the microphones don't pick up the questions.
So my name is Will. I'm from CenterMed. Nobody mentioned anything about the fact that commercial insurance has been subsidizing Medicare and Medicaid for 40 years. Are we ever getting serious about that?
So Will from CenterMed wants to know, are you guys getting serious? Is the industry getting serious about the subsidy from commercial over to Medicare and Medicaid?
We'll leave that to our health plan expert.
What subsidy? Come on, Will.
The answer is yes. Yes. I mean, yes. We're very aware of this. I mean, we're very cognizant of this issue, and hence we are trying to identify strategies to, to impact that, so that we're not seeing this cross-subsidization happening on our Medicaid and Medicare. I mean, obviously we're challenged because of the reimbursement issues, and also, with Kaiser, as an example, we're really committed to serving this population. We think it's the right thing to do because, and one thing I didn't mention, part of the reason we're in the Medicaid space is because we believe also strongly in the continuity of care and coverage. So if a member loses their job and then qualifies for Medicaid, we want to be able to give them the option to stay within the system and maintain their primary care and other specialty care services. But I agree. I mean, that's constantly something we have definitely targets in terms of identifying, what kind of savings we need to achieve to be able to ensure we're not having commercial over-subsidize the other lines of business.
I think it's a definite dilemma.
Yeah.
I would say, though, that an unproductive, unhealthy member of society still gets subsidized by the population, by the community, one way or another. And it is something that we're going to have to address. I mean, if we can really, I think, effectively care for the entire health and well-being of our community and develop more productive citizens, then overall, I think that takes care of itself.
It's a challenge. I agree. And having spent the last 6 years in Ireland, where everything has a price associated to it, and you think there's this transparency, cost shifting goes on in all those markets in the UK and Ireland, all over the world as well. And I think the same challenge that we're trying to figure out here on how you have more transparency in pricing and costs and value are the same challenges everybody else is facing too.
I'll ask you all to think about, those of you who are thinking about entering healthcare, or you're in it and you're moving in your career. One of the challenges we all face, I would ask the panel whether they see this as a challenge when we look at transforming care across the country, and you're in a region, you want to transform care, that one of your big concerns is, what if I do really well in a year and the health plan or the commercial payer or CMS looks at that and says, whoopee, we're going to pay you less next time then. Good job. Congratulations. So there is another fear here to think about, which is that, especially with the cross-subsidization, if I can show my Medicaid costs are lower, the question might be, well, if you serve everybody that way, why are your commercial costs so high? So there are a lot of strategic challenges with this, which is also, again, why it's not a simple question. So, good question. Anybody else? Yes?
Hi, I'm Annie from Valley Presbyterian Hospital. And my question to the three of you is, what do you see as the role of the community and the hospital or the system engaging the actual community where the members live? Because so much of what was said today was the role of the social economic factors that influences the population's health. So what role do you see each of your organization playing in engaging the leaders in the community to really set these structures up to support the population?
So repeat it for the streaming. So Anne from Valley Press to repeat the question, basically would like to know, what is the hospital's role as a leader in bringing the community together, as some of you all talked about, in terms of bringing those community services to benefit the member?
From a hospital perspective, I think it's a huge responsibility of ours, and I think you see more and more hospitals regardless of their organization or structure, are partnering with FQHCs and other clinics and community clinics in the state, as well as doing their own types of community-based models of delivery in order to improve access and be able to offer services to a much wider swath of the community and be an effective organization. I think there's an enormous amount of momentum behind that, and we see most systems engaging in community-based contracting and activity of their own.
Yeah, no, I mean, and I think you probably saw from my brief discussion that, you know, there's definitely a commitment to engage in stronger partnerships with the community. You know, we have a very strong community benefit. We provide dollars to the community. But that being said, you know, there's more we can do. I mean, you know, I'll give you know, we have community partners that are saying, you know, why don't you contract with us? For services, we can do this for you. And you know, and I mentioned, I think that, you know, Kaiser wants to you know, be the model and do everything within its organization. But at times we're starting to realize, I think, that there are certain expertise and obviously community ties that these agencies have that we may not be able to fully, you know, do or, you know, develop. And so here's a chance to really partner, and not to mention the fact that, you know, that our members are telling us, you know, that, you know, I do see. I had one patient actually in the clinic who said that she goes and she doesn't. They signed her a care manager in the primary care clinic, but she talks to a care coordinator that was assigned to her at one of the community agencies that she had been going to in the past, even before she came to Kaiser. And she said, how come you're not getting the information from my care coordinator? Work with that individual and work with that organization. So now you have to talk about good information exchange, good partnership, interdisciplinary care teams. I mean, I think those are all that's the future in my mind. That's where we need to go.
I'll give you an example of how we're doing that. So, you know, part of my role in my organization, I believe, is my responsibility also to engage with the community and give back. And as a board member with the East Los Angeles YMCA, I was facing an organization that was struggling to figure out how they covered their costs to continue to offer the services they do to the community around health and wellness, around workforce development, around education. And so as I started to think about the challenges they were having and started to think about where we were evolving as a healthcare organization, fundamentally, I'm committed to not reinvesting resources in our healthcare system that are already embedded in the community. For instance, I don't believe that I need another orthopedic surgeon because the hospital down the street has one and I need to compete with them. If we have enough in the market, we have enough. And that's the same approach I took with the YMCA. I looked at the services that the YMCA was offering around health and wellness, bringing a CDC-approved diabetes prevention program to the community. And we said, how do we really help this organization be successful long-term? And so we developed a health committee, and I chaired a health committee to start focusing on the health issues that the YMCA can address and that we can address as partners. And what came out of that now is we've opened 2 clinics in the East Los Angeles area, one in Maywood, one in Montebello, and we have one in East LA and one in Koreatown coming up. But they're embedded right next door to the YMCA. And fundamentally what that does from a care coordination perspective, for instance, and from a compliance perspective is now a physician in the community doesn't have to say, you need to go find a smoking cessation program, you need to go find a nutritional counseling program, you need to go get enrolled in an exercise program. This is an organization that has the same mission we do, faith-based, not-for-profit, there to serve the whole community. And today the doctor can say, you're going to leave my office right now, you're going to walk across the road and you're going to meet with this gentleman, and they're going to get you engaged in a program that's going to serve your needs, and I'm going to check on you in 30 days. You're going to be right there, and we'll check on you. We funded their CDC diabetes prevention program. We could have easily gotten grant funding ourselves and philanthropic support to do it. And we said, how do we take our dollars and help that program be successful and use it to its fullest? We're now at the metro level of the YMCA in Los Angeles looking at those same issues, how we do that across the 26 YMCAs through Los Angeles. But it's one example of the way that we try and engage our community, most effectively use those resources. The resources that the YMCA provides our managed care organizations, like IPAs, are paying probably at least $10 per member per month to replicate those same health, wellness, preventive medicine services. And we've got a great community organization that's already doing that, and how do we help them be successful?
Other questions? Sir?
Great, thank you for a wonderful session. My name is Sandeep. I'm a graduate student at the Anderson School here at UCLA. A question for Dr. Mohanty about Kaiser. Is there any evidence to date that the Kaiser system, as a vertically integrated system, has controlled costs of care better than the national averages if you look at CMS data or whatever your cost benchmark is? And has that been statistically significant over some period of time? And I do have a follow-up question.
Let me just start with that one. So Sandeep from UCLA MBA program has a question. His question is to Dr. Mohanty. Do you have data that demonstrates that Kaiser has a cost containment outcome that is better than other folks across the country?
Yeah, I mean, I think, I don't have the data here with me, so I can't really cite it, but we have demonstrated that, that based on the, the integration model, that we have been able to improve efficiencies and reduce costs, meaning we've been able to divert hospitalization costs into the primary care setting. So there is definitely some shift that has gone on as a result of the integration, as a result of the technology around making messaging via email, secure emails, and things of that nature. So there absolutely has been. The issue we face in Kaiser is also our unit costs are quite high in terms of just how we run the hospitals and our facilities. So overall, we may unit costs are actually in some instances higher. We also have our salaries tend to be on the higher side too in terms of so I don't know the exact answer, but we have demonstrated on that there has been a shift in our cost in terms of actually delivery of services from that standpoint.
You have a follow-up?
Great,
Yeah.
Thank you. And then the follow-up question is, there's been recent research, this is from the health insurer side, from United, Aetna, and Anthem, which are now going to be the three biggest in the country, that a lot of the premium increases are attributable to, the biggest factor from a correlation standpoint has been prescription drug prices. And then probably the second biggest factor has been last year's premiums. So a lot of these companies are basically taking last year's premium level and then just applying some rate of inflation or some nominal percentage and just increasing, all of our premiums by some percentage. Could you maybe talk about those key drivers and particularly the prescription drug piece? And it would be interesting, Joel, from your perspective overseas, where the approval process for drugs is different than the FDA's, where there's not necessarily a recognition about cost, or there is a recognition of cost, perhaps more so for the European authorities and other agencies versus the FDA, where here we have such a focus on safety and efficacy, and kind of how those are contributing to premiums, because the recent data from the health insurers is pretty revealing. Thank you.
I'm going to try to repeat that question. So it's a good question, and what I'm hearing is that looking at the large publicly traded health plans data sets and what they're reporting that the reason costs are going up is primarily twofold. One is pharma, and the other is premium. And I'm just going to, a quick annotation from my perspective that I want you all to think about with this is that, think about their mission. What is the mission of United, Aetna, and Anthem? What's their mission? Maximum shareholder value. So don't forget that when they give you data on their rate increases. I'll throw it over to Joel.
Well, just on the European side of this, the EU is responsible for regulating pharma standards when it comes to product and quality control, but the individual EU countries set their prices. So what my experience has been in Western Europe and Central Europe are that we too face challenges on managing our costs because on the public side, prices might be controlled very tightly, and because the government subsidizes overruns. On the private side, coming from Ireland, where I managed a private hospital, Pharma increases continue each year as well. They're not like we see here in the States because the state itself of Ireland and other countries control the progression of price increases through very tight regulation. But it's still a challenge. We just have the challenge on speed here in the States. And a lot of that, I think, to some degree is there is some truth. There is a lot of R&D that goes on here. There's a lot of R&D that goes on in the EU too. And I don't think that that the investment in research and development in the European Union is something that's very, very small comparatively speaking to the States. So I think Big Pharma has leveraged that and has the ability to exploit that in pricing here in the States where they don't have that abroad. But it's still, managing down pharmacy costs and utilization is a challenge, even working in more regulated environments, more socialized environments in Europe that are under much tighter margins than we have here in the States.
I mean, what I can just say is, obviously the challenges that we face in pharma are significant, and I can give the perspective from the Medicaid stand for Medi-Cal here in California. Is Hep C as a big example, the Harvonies of the all those medications we're seeing where there were real challenges with the pricing, and we had to lobby to the states at that with actually our payer, the Department of Healthcare Service, to say you got to reimburse us differently. You can't just put this in the capitation. You got to be able to support to subsidize. So what they did is actually in the Medicaid space is that they came up with guidelines saying, okay, at minimum, you as a Medi-Cal managed care health plan, you have to provide these medications based on these guidelines. Kaiser, interestingly, had already been doing that and actually was they had even more liberal approaches. And that's actually another thing that we're seeing is that, we have a very committed provider population who, staff who are really, looking at the evidence. And so they don't look at the cost piece of it. They're looking at what is best for the patient. So we are, we're also trying to explain to them, but, this is the standard, at least how the state has put it. So we should at least be in accordance with that. Sometimes they prescribe even above that, and that impacts our costs. So we are seeing high pharmacy costs in our delivery system and are struggling with that. So we're trying to put a little bit more maybe utilization controls, but we don't do a lot of utilization management around pharmacy at Kaiser.
I'd say there's a lot of effort in healthcare in general right now to start to control that too. And I think naturally some of the competition that's coming into the market around the plans. I mean, you see provider organizations really finding ways to align meaningfully with their physicians. Things like bundled payments and other ways of working together start to make people pause and think about, the physicians before they write that script. Is that absolutely necessary? How do we start to incrementally save costs within a disease process? And we see as the provider organizations really start to consolidate or coordinate, you start to see them, as Joel said, start to look for that top dollar. How do we move up the chain? Right now I'm working with 2 large employers who want a direct-to-employer relationship with us as Adventist Health. And a lot of it is on how you start to control that cost. And so I think, there's more and more competition coming in with the health plans where people are going to have to be much more cognizant of what costs they incur in a delivery system and how they pass that on to the consumer.
Great questions, by the way. Yeah. Other questions from the group? There's a young lady over there.
Hi, I'm Megan. I'm over from USC.
Fight on.
My wife is from USC. We'll let you in.
Yeah.
You're in a sea of friends.
My question along those lines, I work in quality and I'm really interested to see what types of, with lower reimbursement rates from CMS, with more sick people in the pool, particularly in healthcare, what type of strategies do you find useful or beneficial in meeting those kind of budgets? And what strategies you might find a little bit worrisome?
Can you repeat your name and your entity again?
Megan from USC.
Oh, you work at USC Healthcare?
I'm an intern at CHLA.
Great. Megan from USC, intern at CHLA. And it sounds like your question is around quality and just generally what are some of the strategies folks have put into place to achieve quality and cost metrics?
So you asked, were there concerns as well? So, if I understand the question correctly, at Dignity Health, we have, there's a lot of quality metrics that I'm sure every hospital tracks, trends, monitors, and each year we pick some new ones that seem to keep growing. There's an endless array of things that we're measured by, and we're very measured centric. While the good part of having robust quality programs is they keep, at least from my perspective as a CEO, is they keep our focus. And they keep us focused on the things that really do matter, and that's what happens at the bedside. And they constantly remind us that while we are trying to be good stewards of resources, we really have to make sure that as we're being good stewards of resources, we're improving outcomes. And so, I think there's a lot of new metrics each year that comes down from CMS or comes out by the Joint Commission, or we create our own internally. Are they concerns to me? No, they're not concerns to me. So they're concerns that we don't always achieve them. But I appreciate their contribution to making us a much more focused and much more higher performance organization. I hope I answered that.
Oh, that's great. Actually, I didn't quite hear your question, Megan, and so I'll throw in some thoughts on this. In New York State is working to take control of Medicare as an administrator, and they're also redesigning their Medicaid program. And one of the things that they're encouraging providers and health plans to do is align metrics. So I agree with Joel, and we hear a lot from our providers. Everybody wants to be measured and wants to be successful. So folks don't want to say, please don't grade me. The challenge is that, kind of like I talked earlier about the different payment types, you got bundling and capitation and discounted fee-for-service and all these lots of other different ones. It's the same thing with quality metrics. Every health plan has a little bit of a different take on quality and cost metrics. Then the government has some, and then the employers have their own. And then inside the organization, they have them. And so we've been doing a lot of work with folks, and what we've seen is what's really important is to look at your payment streams, look at those contracts and what's required, look at your licensing requirements, and start to try to line those up. And then when you're negotiating your contracts upstream and downstream with your providers, right, and with your payers, trying to line those metrics up, because the challenge is, of course, if you have too many, right, Don Berwick talked about this in Florida, I think, earlier this year. If you have too many, you end up just with metric madness and you can't hit anything. So a couple of strategies. One is to line everything up. The other is to break your metrics out, though, and say, okay, we as an organization might have 500 metrics, but how many pertain to the physical therapist in that clinic? Oh, okay, the clinic has 10 and they have 5. So those are things that we've seen work nationally, but it's not done yet.
I guess I would just say I don't think the two are really interrelated. And I'll start by saying, Kaiser clearly is the gold standard on quality a lot of times that we're chasing when you look at health grades, when you look at Leapfrog. But, I'll use an example of one of our hospitals, and that's White Memorial Medical Center in East Los Angeles. We serve over 50% Medi-Cal community. White Memorial has zero debt, has large cash reserves that allow us to develop programs. For the last 6 years, we've been one of HealthGrade's top 5% Distinguished Hospital Awards. We have an A rating in Leapfrog. And it's been the intention of knowing we have to be good stewards with our resources that continue to make us focus on that quality. So I don't think that the lower reimbursement necessarily directly relates to a potential loss in quality. I actually think that if you have a commitment to focus on quality, you're going to focus intently on quality and you're going to make it work, irregardless of what's happening around the payer stream.
And I would just, I think, and I do appreciate, Kaiser has really, done an amazing job of trying to keep, maintain and improve quality on a constant basis. And again, and any of the work that we're doing to improve or reduce, improve savings or reduce costs, or look at that affordability, quality can never be compromised. So regardless of the efforts we're taking, especially with the reductions in reimbursement, our quality standards, we're always striving to maintain or improve those. And I think for us, one of the things that has helped Kaiser, as you probably know, is the electronic health record. We have, because it's so integrated, there's an ability to be able to see what is happening with the member, and they've actually put into place a lot of alerts for the providers so that they know right off the bat, you come and see this patient and there's something flashing in your face that says, this person needs their vaccination, this person needs their annual mammogram, those kind of, or whatever it is. So there's those ticklers, those reminders, and that helps, also in terms of at least preventative screenings. But there's a real commitment, there's a real culture in the organization as well to that quality is a prime focus.
Other questions? There's one.
Hi, my name is AJ from Molina Healthcare, Kaiser. Speaking more specifically about quality metrics, and I thought it was a really good point on aligning us correctly financially. Where can we get the dollars to get quality outcomes? What kind of pay-for-performance metrics or programs have you guys seen? Maybe from different health plans that you think are areas of interest for the future, or you'd like all health plans to get on, or maybe some hopeful pay-for-performance programs for your providers.
So AJ from Molina asking, what kinds of pay-for-performance programs have you seen? Maybe what have been successful? And I'll start just with a quick take on that, is that high-performing health systems and provider groups, what they really need from health plans is they need as much of a subcapitation as they can possibly get, with really clear divisions of responsibility for those dollars, and then obviously some insurance and some work with them to bring them along if they're not quite ready to take risks, so you have to figure out where they are. But when we work with folks, what we generally find is that there's a challenge between how the health plan makes money and how the providers make money sometimes. And so to the extent that health plans can work with provider groups that have the right networks in place that are doing the work these folks are talking about, and then really just give them enough of the risk dollar to do the work, we found that to be really effective. And the challenge we found is that folks who are taking risk and doing really well with it have so many other pieces that they can't get the full risk for, that actually makes it a little bit complicated for them. This is, of course, outside of a Kaiser. So that's just my take, but I'll throw it to the committee.
I'm going to defer to my colleagues to my right, because this is my first year of pay-for-performance in the States. We launched pay-for-performance metrics with the VHI, which is the largest private insurer in Ireland when I was there. And they adopted a number of UPMC's and CMS metrics that because we were measuring them anyway. Regardless of whether UPMC had a hospital in the States or whether they had them internationally, we had international measures that we built onto the CMS ones. So you'd be closer to it.
I mean, I can maybe speak a little bit. Kaiser, our physicians are salaried. That being said, there is a quality bonus that's attached kind of to the providers based on quality metrics, and so there is opportunity for medical office buildings or physician groups within the Kaiser system to attain a higher bonus as a result of how they perform from a quality standard. So we do have that. When I was at LA Care, and maybe Roland could speak to this a little bit too, we have a pay-for-performance program that really outlines basically mostly focused on HEDIS measures, but also on one of the things we instituted there was also in order to be able to demonstrate quality, you need to have the data. So we actually used, one of the incentives was the ability, if you are able to provide us with those quality data, we'll actually give you a subcapitation, some payment on top of that. So I'm curious, actually, this might be a question to hear if how that has worked, and we thought we actually mirrored a lot of that pay for performance from other models throughout the country and other Medicaid managed care plans, and at least it gave some additional revenue to the groups. But
so,
yeah.
I'll talk about a number of ways that we incentivize our physicians in employed models or other aligned models on the independent side. I guess what I would say is precisely to Sarita's point, and I was going to make that point, is physicians and healthcare providers in general want to do the right thing. They want to provide good quality care. The incentive isn't a little more money to do so. Probably the much bigger incentive is how do you share data that going both ways, that really helps inform people and help them make the right decision. I mean, the challenge with meeting some of these metrics isn't that we're not getting enough money to do it. It's that we don't get the data in an accurate, timely way that helps drive good decision making. Mm-hmm. And it's our responsibility as providers to be able to submit data, and also then to have that data come back to us and give us benchmarks and help us understand contextually how we're performing. And I think for any provider that's really committed to their patients and their community and being a high quality provider, it's that component that's most important. Give us the data that helps us make the right decisions.
Other questions? Please.
Hi, my name is Erlyn. I recently graduated from UCLA, and I graduated under communication studies, but with a huge interest in pursuing healthcare. And I'm currently involved in some research. And one of my questions to you guys is, I hear a lot about healthcare providers intervening and creating these models, but what have they done to outreach to patients and receive patient feedback that could potentially help us to justify these costs and figure out where we can invest more money in pursuing better quality healthcare for them?
Can you repeat your name, please?
Erlyn?
Erlyn, thank goodness, is from UCLA. So right away, she gets points for her question. Erlyn's question is, hey, this is a great discussion about providers and health plans and everything else, but what are you doing to talk to the patients, the members, about these changes, and how are they having input into where you're spending your money and where you're making your improvements?
So I guess I'll start, and we'll all comment on this. And interesting, Alan just said two words together. He said patients, and then he said members. As healthcare providers, we're very engaged in hearing the voice of our patients. The sicker you are, the more times you're coming through, the more times we're going to survey you and find out what you're really looking for in your healthcare. As Alan said earlier, the reality of managed care now is it's really 90% of the population that's relatively healthy that subsidizes the costs and allows you the dollars to provide the care that's necessary for that 10% that's sick. We're still trying to transform our thinking to say, how do we spend enough time and energy reaching out to those healthy members to understand what value in healthcare means to them? It's not that we're going to recreate the sick care model to be more effective for the sick care only. We need to figure out what provides value. Joel talked a little bit ago, I think, about wellness programs with the employees, and that's one of our testing grounds. We launched and engaged in a non-engaged plan for our employees, and there's a number of value-added benefits. You know, there's discounts on Fitbits, there's free Weight Watchers programs, there's different exercise programs in social environments that are set up to encourage participation. There's a patient portal where information flows in and encouragement for biometric testing. And there's a lot of things that are happening. And, you know, I made the comment as I started that a lot of these areas we're investing in is kind of research and testing, and we're learning where we're failing, and we're learning to improve that. And we're looking to develop a model through that defined population of employees that allows us really to reach out to the healthy and well in the community. Another thing we're doing, as I talked about the YMCA relationship, is within the YMCAs we've embedded information centers and programs that are proactive in keeping people healthy and well. So not only are we giving them support financially for their programs, but we're investing human resources into their centers. You know, as people move from fee-for-service into managed care, there's so much confusion as to what is the best network of care for me personally. And so we've invested in those resources to help educate them, and then programs to help connect them to exercise and healthy options in their community.
Sarita and Joel?
Go ahead. I think that question is excellent in that, you know, you can't ask patients and, you know, members, you can't ask them enough about you know, what they see as important in their care. You know, we have, you know, in the Medicaid population in particular, because, you know, we're learning about how to address some of the other needs beyond the medical care needs. We've had to rely on really talking to the patient and to the members, who are the ones that don't come to the hospital or come to the primary care clinic. Engage them and say, what's a good day for you? What's important for you in your health care? You know, we've done focus groups, we've done key informant interviews. You know, when we wanted to find out about the ED, the high emergency department utilization, those patients who were using the ED a lot, we actually reached out to them and said, why are you using the emergency department? So asking those questions is critical. But I think it's really important, even whenever you see the patient, you happen to see the patient in the clinic or in the hospital, asking them what's most important to them is really, I mean, just engaging them and understanding their priorities is really important. The other piece I would just say also, in addition to talking to people that seek care and those that don't seek necessarily routine care, the caregivers, the family, I think is equal. It's just important to ask, talk to them and engage with them. And we've been trying to do a lot of caregiver outreach and to really understand that, yeah, you have, mom who's, showed up in the hospital 3 times in the last month, but how are you doing in all of this? Because if, what we often find is that the caregiver gets sick and then, then you see this downward spiral in both of their care. And so anyway, so that's some of the approaches I think are very critical.
I think your question is a really important one, because I don't think there's no standard approach that hospitals are taking to determine consumer value or what the perception of value is by a consumer that utilizes a hospital. Hospitals are really good at using claims data and utilization data to determine demand and predict demand. And we're programmed to do that because it's something that we have. We have data on it. We can slice it and dice it and figure out how we glean that. Or we use our joint operations committee meetings that we have with various health plans and physician IPAs to kind of get a sense of what consumers want, and we're constantly told what they want without actually necessarily getting the real scoop directly from the consumers. So to Roland's point, we really do, this is a formative stage for us. This whole transition from fee-for-service to fee-for-value and how we assess what it is that we should be doing and what it is that people want and where they want to receive it. And so we are using, I know at my hospital, we're using the employee narrow network to sort of help us identify kind of what consumers want, where they want to receive care and how they want to receive care. And we use our outreach activities in various market segments at our hospital. More than 50% of our hospital identifies themselves as a Spanish speaker first. And so we use our Latino outreach services to kind of give us more information about what that community wants. Or we have a large Southeast Asian community in Long Beach that we learn from and tailor our services over time to what we hear they want. But I think there's going to be one of our things I think every hospital and health system is going to be dealing with in health plan in the future is, as we diversify our services, each consumer segment that we cater to has a different style of how they want to receive what they want to receive and where they want to receive it. So it's incumbent on us being receptive to that.
We're going to take 2 more questions. Oh my gosh, I recognize that man.
No. Hi, my name is Jay from UCLA Health. We spoke a lot about a lot of the impacts coming in and some of the investments we're currently making now. From 3 different perspectives, I'd like to know ideally what the healthcare market would look like 10 years from now. If everything that you did comes to fruition.
All right, so Jay Wan, esteemed alumnus at UCLA at the Medical Center, has a question for y'all. He wants you to tell him, if you do everything right, if it all works out, tell me what it looks like 10 years from now. So we're going to tape this, of course, and play it across the country in 10 years. So
I did play Powerball when it did hit $1.3 billion. I don't have the answer to that. I imagine it's going to be much more data-driven, much more consumer-focused, and much more focused on how we reduce our cost model down to manage more and more people's lives more efficiently and in a more cost-effective manner, while we're at the same time being held accountable for outcomes. So I don't know what that looks like. I just know that's the direction we're moving in.
Well, I can say kind of my ideal, I don't know if we'll get there, but I hope we can. Is really to, one is to really focus on bringing care closer to the community, to the home, as much as possible. And we have, opportunities to do that, as we talked about. And I do think technology is going to have a key role in care. So I imagine in 10 years, you're going to see so many different technology-enabled ways of managing members, communicating with members. And also, again, it won't be just talking to that person, that individual who's seeking care, but also the family and engaging the whole support system. I think that's going to be really critical. I agree. The data piece is going to be, we're going to be seeing a lot of that. In the ideal world, we will have robust data exchange that crosses the whole continuum. So you'll not only just your hospitals and your providers, your Kaiser, you got your hospital, you got your physicians and all that, but we need to be able to communicate with all those entities outside, those carve-out specialty mental health services. The ability to be able to share data with them would be phenomenal, right? To be able to coordinate that care. We can't do that right now. And in effect, we have to get releases and HIPAA, so I could go on and on. If I had if I had my wish list, those are some of the things that we would try to cross off the list. So,
yeah, I mean, that's a huge question. I agree with Sarita. I think patient monitoring right now and the technology coming around that really will change the way that individuals take control of their own health care. And I think their consumer voice will drive some of the changes that we'll make. What I will say is what I've been really impressed with is I've been able to see different healthcare markets. I had the opportunity to go with Alan, and we visited Korea 2 years ago. And if I was to look at an ideal state, or at least at the part I saw, it was interesting to me as we were touring different healthcare facilities, and the country as a whole really has a strong focus on preventive medicine, early identification of disease. You know, the citizens in South Korea are tested yearly, and it's not as simple, you go see your doctor, you get your physical. There's very involved invasive testing that's done, but as a result, they catch disease at a very early state, and so the incidence may not be less, but the treatment is much more effective and the outcomes are much better. And I asked the question, I said, if I'm uninsured and I'm walking into the ED today and I've injured my knee, what's the cost for me to see a doctor, get my meds, get a diagnostic image, and how does that process work? Well, what do you think the cost is? Huh? $45 as an uninsured person to go to their ED, see a specialist, get a diagnostic, and well, again, the subsidy from the government overall, because disease is at a lot lower state, I think creates a healthcare system that's much more efficient, and it's not so heavily subsidized. And so when you look at how do we start to move toward much more intentional preventive medicine, much more early identification of disease, the other thing that happens over there, unlike here, is if I wanted to get surgery, I would be NPO that night and I'd be having surgery tomorrow morning. Through the systems, at least as they were described to us, and at least the part we viewed, healthcare moves at a very rapid pace. There's not the see your primary care doctor today, get scheduled for your MRI 2 weeks from now, and all during that time you're unproductive in society if you're truly injured, right? And then you're waiting for the MRI results to come back so you can see your specialist 3 weeks from then, and then your specialist says, well, we need to get you into surgery, so 3 weeks from then you're going to get scheduled for surgery, and then 3 months later you've got your surgery and you're starting rehab. I mean, here it was identify the disease, treat it tomorrow, get you back into society productively as quick as possible. And that, to me, whether we saw it fully and completely or whether that was just an ideal state, that's what I would envision I'd love to see us get to. And it definitely won't be 10 years, but hopefully we get there in my lifetime sometime.
One last question.
My name is Neeraj. I'm an alumni of UCLA Anderson, 2004, and we see some familiar faces here, Orlando and Shrika. So just I'll be quick. So historically, there's always been tension between the provider and the payer. And I got a startup that does real-time patient tracking to improve patient flow, patient experience, and I got investors both on retired CEOs, hospital CEOs, and I got chief operating officers of payer companies both on my investor list. And I do see that historically there's been a lot of tension between the provider and payer, but with all the reforms that are being rolled out in the last 3-4 years, you actually see, like the payers, for example, population health, right? It needs the payer and the provider to work together, a lot more positively than what we did in the past. So you actually see that happening, and obviously, Sarita is all integrated, but this is more for Joel and Roland to answer.
Can you please repeat your name? Pardon me.
Neeraj.
So Niraj from UCLA Anderson School, the question is, particularly for Roland and Joel, because Sarita's in an integrated system, is do you see, similar to Jaywan's question in some ways, do you see payer and provider integration improving? Do you see them overcoming some of the challenges of the past and doing a better job of coordinating and integrating in the future? Or do you see it happening at all?
I guess I'll start by saying, yes, I definitely see it coming together, and there are a couple forces driving that. I think general healthcare consolidation in the market starts to drive that because, again, what made it work well, I think, for the payers and the fundamental role they played was really organizing healthcare from a highly fragmented system. So as you start to really organize the providers more and more, and they have the ability to be a potential payer, then it really becomes the question of where's the value that both parties can provide working together, the payer and the provider together. And there's some beginnings of ways we're testing that. We're working with Blue Shield, for instance, on a clinically integrated network to say, how do we start to work together as a payer and a provider in decreasing the healthcare costs and increasing value? Doesn't mean we need to go out and do it on our own. We can work with them and share data back and forth and understand what value each entity brings in helping to manage a large population of members.
I haven't seen complete alignment yet, but what I do see is both payer and provider both having a greater willingness to create value within their own organizations, create value for their subscribers because they're shared between the hospital and the payer at that point, and each have a willingness to contribute to the value equation. And I think, more so now than ever before, with the Affordable Care Act and all kinds of other external pressures on hospitals and payers both creating efficiency, and that's trickling into how we work and collaborate more effectively with physicians because they're right in the middle of it all. I think the willingness is more now than ever, and I think that's inspiring new and different conversations than maybe we would have had 10 years ago.
Well, I don't know about you guys. I thought that was pretty cool, and I want to start by thanking you guys and tell you as an audience, you're the coolest question-asking audience I've seen in a long time. Now, I'm sure it's because we're at UCLA and not USC. But in all sincerity, I mean, those are, thank you, great questions. I don't know if Dr. Torrance went around to each of you last night and had a conversation with you about what questions you should ask, but that was a really impressive set of questions. So I want to thank all of you. I certainly want to thank our esteemed panel. These folks are incredibly busy, right? Big hand. They all took time away from their combination of work and family that they try and get through every night. And traveled and came here. And so I just want my deepest appreciation for traveling all the way to Westwood for this and for wonderful presentations and answers. And thank you all. And I hope you all have a wonderful evening. And signing off for UCLA.
Thank you, Alan.